My name is Sanjeev Bhalla, and I'm a professor of radiology at Washington University, and I run the cardiothoracic imaging section here at the Mallinckrodt Institute of Radiology in St. Louis, Missouri. Certainly useful to keep in mind that patients who are started on immunotherapy can develop a pneumonitis, and that pneumonitis will have findings of organizing pneumonia. So that's often easily discerned from whether it's cancer progression or not, because all of a sudden you see these findings of organizing pneumonia in various parts of the lung. The hard part is in this entity that's been called pseudoprogression, which, as has been relayed to me by many of my colleagues at Washington University, was well described with melanoma, where you have patients who will get immunotherapy and you'll see a paradoxical increase in size of the melanoma lesions as a result of response to the immunotherapy and not progression of disease. And the question always is, do we continue the patient on this medication, or do we stop and try to go to something else because of the potential that that this tumor is progressing? To be honest, pseudoprogression in the chest is less common than what we've seen with melanoma, but we have definitely seen it. We have seen patients here who have pseudoprogression. Our experience has been that the pseudoprogression, where the first study is larger than on the prior, usually manifests in lymphadenopathy and manifests in hepatic lesions. So in my mind, when I'm looking at a patient who's started immunotherapy, and if the progression is unique to the lung parenchyma, I'm much less likely to call it pseudoprogression, because that seems to be very unusual for our experience with pseudoprogression here. On the other hand, if we have liver lesions that we're following in a patient with lung cancer, if we're following lymphadenopathy and those lymph nodes and the hepatic lesions have gotten bigger on the initial follow-up study, then I do raise the question that it could be pseudoprogression, so that my referring colleague can use it with their clinical evaluation to try to help make the determination whether or not they should continue the patient with immunotherapy. So for me, I find it's the solid organs outside of the lung parenchyma that are useful in making that distinction.